All right. Well, I'm going to turn it over to Dr. Catherine Fair, our Chief Resident for Global Health, who is here for a month from her time in Naivasha. Catherine, go ahead and take it away.
All right. Thanks, Kayla. I will just get started. Basically, yeah, I've met most of you. I'm this year's Chief Resident for Global Health. I am based at Naivasha Sub-County Hospital, and I have the privilege of presenting some of the cases that I've seen in Kenya. No disclosures for today's presentation. I just want to send my gratitude to our colleagues at Naivasha Sub-County Referral. Some of the cases are adapted from previous presentations by Chiefs Mike Brody, Colette Abbott, and Lauren Onifrey. And some of the cases also have some references to a textbook called Reasoning Without Resources, which some of you might have used in the past. We do have some polls in the cases. So we'll do about 5 cases. We'll see how much we can get through in the time. The goal is to kind of be exposed to reasoning in resource limited settings and to appreciate some of the epidemiology that we deal with in sub-Saharan Africa, as well as the inequities in healthcare provision. And then I'll do a brief introduction to the Clinical Education Partnership Initiative, which is our month-long rotation for residents in Naivasha, and give a quick plug for the chief here. So in our first case, we have a 27-year-old woman who was brought in the ER by her family for generalized malaise and difficulty in breathing. She is pretty much unable to provide a history, and family tells you that she's been having increasing fatigue. This morning could not get up and go to work. She has no known past medical history. She works as a flower farmer and has a husband and children ages 4 and 6, no other habits, no family history. So when you meet this patient, there's no working thermometer at the hospital. Her blood pressure is 102/86, heart rate 105, and her SpO2 is about 84% on room air, respirating 25. She's young and thin. She's pretty somnolent on exam, and you notice some tachypnea, some kind of prominent what seem like small respirations, but there's no wheezing in her lung fields, and otherwise just tachycardic and no organomegaly and that depressed level of consciousness. We often have it reported in GCS in our setting without focal deficits. So my first question for you all is, what do you want to order? So the patient has been admitted to the ward, which is about $7 a day, certain oxygen, which is about $1 a day, and she only makes about $90 a month. So keeping that in mind, which test do you want for this patient? And we can launch the poll. Great. All right.
We'll give folks sort of enough time for like 3/4 of folks to get in, and then I'll go ahead and share the poll with you, Kath.
Okay, great, because I don't think I have control over that. Yeah, so normally in your, oh, where's the poll? Great. So a lot of you said chest x-ray. You're mostly worried about her respiratory status. That is something, and then quite a few of you want labs, which is a good split. I think in our US hospital, she'd probably get both of those things, and a decent amount of time to get both those things in our hospital. This patient got basic labs, and that's kind of your ballpark prices. So has a white count of about 15, normal hematocrit or a little low, and then that notable blood sugar of about 450. you're getting a little bit of a picture from this, and so you've gotten some laboratory workup, and she has a high sugar and the Kussmaul respirations, and so I think the patient didn't end up getting a chest X-ray because the portable chest X-ray is broken, and we actually end up getting a urinalysis with about 3+ ketones. So in Naivasha sub-county, there's no serum ketones, there's no serum bicarb. So when you get a BMP, you may not know about the acidosis status of a patient. Usually the diagnosis is made clinically. And then with that kind of 3+ ketones in the urine. The reason I mentioned the Kussmaul respirations is that that is kind of our indicator of acidosis. We do sort of recently have blood gases available, but they're not always, reliably obtainable for patients on the wards. So if someone is sick enough, we might be able to get it. This is, a small document, but an example of our protocol, which is pretty similar to what you'd see in the US. We're focusing a lot on hydration and fluid resuscitation, trying to get the potassium level before getting insulin, and then kind of a standardized plan for insulin drip. But we don't have, we have maybe 2 pumps available in the hospital. So they have to sort of titrate the insulin drip based on cranking the tubing and then kind of injecting extra insulin if you get behind. The case continues where the patient does get the standard sort of 10 of IV insulin, and she starts on an insulin drip, gets a piggyback of K+ and fluid, and then unfortunately, she still has Kussmaul respirations, mental status is still not improved, and has kind of unrecordable sugars on blood glucose in the morning. I won't have everyone poll for this because I think you kind of have a hint about what we can do, which is that the portable machine is broken, the CT head requires transfer to town, you have to kind of pay $70 for the upfront cost in order to get it, and the patient is pretty critically ill. But in the last couple of years in Naivasha, we've now gotten an ICU, and the reagent is back in stock. We get an ABG on this patient, and the results are below. So basically, this is a real ABG, a patient with a pH of 6.95, O2 123, PCO2 less than 10, lactate of 2.5. The ICU was able to come and evaluate the patient. Decision was made not to intubate because the anesthetist wasn't available for another hour, but she was moved there for closer monitoring. And luckily, some close monitoring and a bicarb allowed her to discharge home in good condition. So just giving you an example of management of DKA in our setting, it's a pretty common admission, and we are able to get some of the basic tests, but there's some workarounds that are required.
Catherine, real quick, a couple things in the chat before we move on to our next case. Will's asking about the costs of each. Will, I'm curious which test you're talking about that we didn't go over.
Yeah, I asked the question before the cost.
Before the poll. Yeah, sorry about that.
And then we have some color commentary asking if there's pics of the ICU crocs, because that would enhance the experience.
Not in this presentation, but yes, that's one of our infection control measures, ICU crocs. Just briefly about ICU care in sub-Saharan Africa in general, a lot of this data is going to be epidemiologically FSA, just because there's a paucity of data for Kenya specifically, largely due to kind of the Western eye of publications and the money available to publish that data, not that it's not being researched. And we're they're in the sort of like medium orange in Kenya. I don't know if you can see my cursor, but basically there are widespread kind of inequities in the number of ICU beds available across the world relative to the critical disease burden. And I think this is a slide from Dr. Owen West's presentation where we can talk about how at Harborview we have, hundreds of beds, but our hospital has 2, and one could argue a lot of sort of critically ill patients. There tends to be a low number of ICU trained physicians and nursing staff, facilities available, and then oxygen availability can be quite limiting as well. Number of times at our hospital where it's just run out during the day, but those things are all being worked on. So we have case number 2, a 73-year-old man with known hypertension who presents to outpatient clinic with shortness of breath. So he's had increasing dyspnea with his usual activities. He reports waking short of breath at night and shortness of breath lying flat. Has an elevated JVD, his PMI is displaced, he has a regular rhythm, and increased work of breathing with some fine crackles. The SpO2 isn't working for him today, but I think all of you probably have a pretty good guess about what could be in his differential. So we're talking about CHF. This is a also really common reason for admission is dyspnea. This slide is a little bit about diagnosing CHF in our setting. Basically, the Framingham diagnostic criteria, which is a combination of kind of symptom presentation, is actually a pretty sensitive test for CHF. It's not terribly specific, as you might expect. Some of these things like dyspnea and orthopnea are common to other cases. But that will be kind of reported to you by your intern and used as a diagnostic stratification. And then a chest X-ray maybe has cardiomegaly. ECGs are a little bit less commonly done on admission, but that can be another clue. And then we really enjoyed using the POCUS tool to work with local learners. These tables are taken from the evidence-based physical diagnosis textbook, basically outlining which physical exam maneuvers are going to be, or how you might use them as a tool, either for increased likelihood ratio or decreased if you already have a high index of suspicion. So you can imagine kind of using your Framingham on your interview, plus your diagnosis, things like the displaced apical impulse and things like the abdominal jugular test tend to be really helpful in increasing your suspicion, whereas it seems like having a gallop or Cheyne-Stokes respiration is a little bit less of an increase. So we're going to do a fun exercise. Basically, in sub-Saharan Africa, heart failure is becoming increasingly more common. It used to be that valvular disease from rheumatic fever was one of the more common causes of heart failure, coming in at about 25%. Cardiomyopathy is still pretty common at that time. And then moving into kind of the present decades, there's a lot more hypertensive heart disease and ischemic heart disease. We still see some of the cardiomyopathies and rheumatic valvular disease, but also some of the more common things. And so putting these kind of 5 diagnoses in the forefront, dilated cardiomyopathy, hypertensive, post-traumatic, and coronal, as well as pericardial fusion, which of course can have some of the similar symptoms. I want to highlight protocol that was published semi-recently called the Curls Protocol, which is actually in, I believe, South Africa, teaching learners at the level that I most commonly interact with. So medical officer interns to do a single view cardiac POCUS to be able to diagnose the etiology of the heart failure based on different structural signs. And so we'll see how well all of you all would do. See if this video plays. Great. This is going to be a poll. So this is your first exam. I believe this is a subxiphoid view. So we're cheating a little on the single view. Which cause is the heart failure symptom coming from in this patient? I can just keep. Great. So 53% of you saw the pericardial effusion that is just above the right ventricle for you all there. And actually what looks like sort of echocardiographic signs of pericardial tamponade. But of course, you all know that is clinical diagnosis. And luckily, this patient, this is a focus that I did, the patient did not have hypotension, but she was eventually able to be transferred for centesis. All right. Pericardial effusion. So pericardial effusion in our setting, pretty commonly TB associated. I'll often screen patients with TB if they have difficulty breathing even after treatment initiation. And in the case of this patient, it was actually renal in nature when we were able to get the labs. So our next case, this patient is a paraspinal long view, and that's what's going on. It was actually a young woman, about 25 years old. Apologies for the quality at the end there. All right, we have a split vote for post-traumatic and dilated. Those of you that chose dilated would be correct. I'll show a little bit of the difference of the two, but basically, yes, she does have a big LA, which yeah, can happen in post-traumatic disease. In this case, just kind of the thin walls of that left ventricle. You can see a little bit less of the right. She had kind of probably an HIV cardiomyopathy based on history, which is one of the two big causes that I've seen, also kind of peripartum or postpartum cardiomyopathy, more common in our setting and patient population. And then one final image. This one is actually from the study itself, because I didn't have a good image. And this is their, they did the subxiphoid view. Sorry. All right, all over the place. Okay, so this one, the key is going to be that in the xiphoid view, is that correct? We have the really large right ventricle. So it's kind of a demonstration of cor pulmonale. Um, really an interesting kind of epidemiologic phenomenon. Some of you who've been in Naivasha have seen that we have quite a few people with this right-sided heart failure, whether it's from kind of undiagnosed pulmonary hypertension or just probably pulmonary hypertension type 3, just given that people have really low access to home oxygen. They may have had COPD or other obstructive lung disease for a long time, and there's almost no positive pressure ventilation. So development of right heart failure can present late. I've also had to empirically diagnose PE based on a right heart enlargement. So just focus is a really useful tool in our setting. Here's just a brief review of what you might see in some of these conditions. These are all in the same view based on that study, which I recommend you looking up. They found that a training briefly provided to kind of mid-level training providers was able to pretty accurately diagnose these different causes compared to formal echo standard of care. And while kind of diuresis and other things are mainstay of treatment, it does end up being really helpful to know the etiology. We don't often have access to a cardiac catheterization at our hospital, but we can get kind of hypertension control, and some people do get treatment for valvular disease, HIV, et cetera. And that mitral valve disease, which we didn't show an example of, really just more of a prominent LA, but it's not dissimilar from the dilated cardiomyopathy. Great, thanks for playing. We have our third case. So this is going to be a 34-year-old woman who presents with abdominal distension and malaise. She's had it for about 3 months and some weight loss, anorexia, now with, I mentioned that twice, diarrhea, and also showing evidence of jaundice that she's noticed and her family's noticed. She's fatigued with the scleral icterus. She has some organomegaly, hepatomegaly, and you appreciate a fluid wave, maybe some trace lower extremity edema. And so just to summarize, maybe this is a young woman presenting with subacute ascites, weight loss, and constitutional symptoms. You did go ahead and get the basic labs that are available with her LFT as being normal, but her Billy was about 2 times the upper limit of normal. And in-house available would be like the sputum gene expert for TB, because of course you're thinking about constitutional symptoms and weight loss in a younger lady. And her HIV, HBV, and HCV were all negative. And then you're able to get a fluid tap. Those studies sometimes done outside the hospital. In this case, it was just an LDH and albumin that was run on the fluid, but it's pretty abnormal. This ends up being low SAG ascites with a high LDH. So with that in mind, what additional study do you want to do? We can launch a poll for that. Right, so kind of a tie between the fluid gene expert and then the ultrasound of the abdomen. We're kind of both going for the cheaper options, which is okay. It's good to start with some things that you think you can get easily. Both of them are available on site. So thinking about low SAG ascites, of course, TB, as we often say in our setting, TB until proven otherwise, particularly in this young woman. But we're also starting to worry about malignancy, that really high LDH kind of things not fitting together. And then pancreatitis, nephrotic syndrome, bowel obstruction can also be reasons to have that low SAG. She did end up getting an ultrasound. She declined the transvaginal ultrasound, but got an abdominal that was originally read as no abnormality. Then ended up getting a CT, which we had an overread of a possible ovarian abnormality. And then we were able to repeat that on ultrasound. The gene experts, just the point I want to make with that is that in acidic fluid, it's pretty not sensitive. I think it is useful on LP fluid. It's incredibly sensitive for sputum, but we don't typically get it on acidic fluid. I think the diagnosis often has to be in biopsy of the peritoneum to have peritoneal TB. So sometimes you're lucky and you can get a diagnosis from elsewhere, but sometimes you have to treat empirically. Unfortunately, this woman did have a gynecologic cancer, which was fairly advanced. And the point I want to make with that is that in our setting, the causes of death in Kenya have kind of changed in recent years, such that we still have quite a bit of infectious disease, HIV, kind of spearheading a lot of those different opportunistic infections, but cardiovascular disease is also on the rise, and cancer. These are the types of cancer that are most common, similar to the US. Breast cancer for women is one of the most common. You don't see lung on here as that common, but certainly a lot of esophageal cancer, and then cervical cancer, along with some other gynecologic cancers, are common and quite sadly late presenting, just because of the low access to screening. So the Ministry of Health has been leading some campaigns to do so. Currently, the vaccination rates for HPV are pretty low, but just giving you an eye to kind of the preventative end. Subsequent to that, this is a slide from Manoj Menon, who's one of our oncology faculty. Basically, there are kind of less palliative care outlets than we would like in the setting, and palliation just in terms of kind of having doctors with an understanding of pain, and those who are able to cater to some of the overwhelming consequences of disease, and something that our hospital is lucky enough to have a palliative care team associated with the oncology department, who can come and see patients. But I think it can be one of the biggest challenges in terms of your practice, your difference between being at UW or somewhere where you're able to have some of these big family meetings, and this sort of time to be able to communicate these things in a culturally sensitive way, can be less. And we've had some kind of young deaths and things where you'd want those things to go differently. And this is one of the biggest gaps, is being able to really feel like they have control over the process of life-limiting disease. There are also some interesting studies from sub-Saharan Africa about understandings of chronic illness. So because of this previously largely infectious disease, you'd seek care in the hospital and maybe get a treatment that returned you back to the community. But with increasing amounts of things like ischemic heart disease and cirrhosis, patients' understanding of the need for continued treatment, which I mean, I think we can all say even in the US with our patients who have heart failure, once they feel better, they stop taking meds. So things are not so different at NSCH. And as I've been kind of alluding to with these first 3 cases, what about all the tropical medicine zebras? We've been looking at heart failure, diabetes, cancer. Strokes are incredibly common. So while the epidemiology might be slightly different and our treatment might be slightly different, we encounter many of the same things. And those of you that have worked in global health will kind of understand this IHME diagram, which is the causes of death and disability in Kenya. It's kind of a percent increase diagram. So big advances made in HIV, although never enough, but down about 40% in terms of deaths, and down a little bit in diarrheal and neonatal disorders, but still rising rates of ischemic heart disease, cirrhosis, stroke, some of the other conditions that we see most commonly. And unfortunately, at the same time, dealing with both of those leads to some pretty sick patients. All right, so moving right along to case 4, we have a 52-year-old man who is HIV adherent to treatment, and he's just on first line and some Bactrim prophylaxis, and he's presenting with 6 months of fatigue, headache, and weight loss. Endorses a mild dry cough, but denies fevers, diarrhea, visual changes, or neck stiffness. On exam, he's cachectic, but in no acute distress. You're able to get a temperature today, 37, heart rate 112, 106 over 74, SpO2 of 90% in room air. He's respirating around 14. So you notice pale conjunctiva, no scleral icterus, and a 3 out of systolic murmur on the left sternal border, nychia, clubbing. So I'll give you a moment to kind of think about this patient, how you put him together, adherent to treatment. So hopefully immune constituted, but drawing out that maybe constitutional symptoms, subacute to chronic, with some evidence of pale conjunctiva and tachycardia. So you go ahead and get the basic labs. These actually are done on admission for most patients. So I ask you guys to kind of challenge yourselves with it, but it is usually at least once that we get this panel. And he does in fact have a hemoglobin of 5.8, which you're sort of clued in with the pale and the tachycardia, really, really common to be this anemic on presentation, but he does have a white count of 3.2, absolute limbs of 0.9. And the CD4 reagent wasn't quite available for this case. We don't usually send iron studies into the community. And we can kind of be clued from the MCV of 64, microcytic anemia. You're able to get a chest X-ray for this patient. So I'll give you guys a moment to review. And so we're thinking about a patient who's immunocompromised with some treatment, maybe evidence of worsening anemia along with a cough. In this chest X-ray, which is pretty well penetrated and good inspiratory results, we have good bony alignment. We see some no effusion at the diaphragmatic borders. His cardiac shadow is also pretty clear, and I see some kind of traction air bronchogram, maybe on the right, some increased hilar fullness, and then I think kind of throughout some patchy interstitial opacity. And so what do you think is the most common or the most likely cause of this patient's anemia? So it's a microcytic anemia, just to remind you, and we're wondering if this is TB, is this spectrum causing myelosuppression, direct HIV-related myelosuppression, H. pylori associated PUD, or a non-Hodgkin's lymphoma, which can be associated with EBV. All right, we're all over the map. So agreed, all of these are possible causes of anemia in our setting. Yeah, peptic ulcer disease is incredibly common, not quite this patient's history, but usually we do end up screening. The answer ends up being TB until proven otherwise. So actually, Mycobacterium tuberculosis, a cause of anemia and HIV, TB and HIV co-infection affects both disease processes, making basically in Kenya, most patients with tuberculosis will have HIV, and the other way around is obviously a little bit lower percentage, but the complications of tuberculosis end up being revealed either when someone has low immune, or as some of you have heard of IRIS, when someone gets treatment for HIV, they may end up with complications of tuberculosis. So it's severe anemia is strongly suggestive of TB in HIV-infected patients. This was a study out of Malawi that basically TB can kind of cause a presentation with anemia alone, and you might not necessarily see this target kind of lesion on chest X-ray in a patient who has HIV. TB is a really common cause in HIV, and often it's worse in later stage when presented. So a lot of our patients who come in with, as we call retroviral disease or RVD, end up getting empiric treatment for TB if they have a cough. They may not always have that cavitating lesion. In the reasons for this anemia presentation is TB is quite iron avid, can have direct bone marrow inflammation, and like we said, it can be an abnormal presentation in HIV. It is not always in common practice, but some isoniazid preventative therapy is given for HIV patients just because of the kind of enormous complications of having co-infection with both diseases. TB can present in many different organ systems, and so this is an example of anemia. I talked about a case at Chief of Medicine last week about a TB meningitis, which I've seen various times, and we also, of course, mentioned TB peritonitis, TB pericardial effusion, so it can go to lots of different places. TB is diagnosed in this patient, in this case, by gene expert, as we talked about, a pretty simple and quick test on sputum. And then when do you want to initiate treatment for TB? So this is a poll. Remember, we're working in Naivasha Sub-County Hospital in this case. All right, so most of you chose giving RIPE and ARVs now, and some of you wanted to wait a couple of weeks, some longer. So this is a great, I think answer A is going to be the correct answer, largely in our setting. In the US, but sometimes in Kenya it can end up being choice B. So I'd say mostly the top two are correct. This has a lot to do with just monitoring. So sometimes the continuity of care clinic for HIV will guide our inpatient management of HIV. And if they're newly diagnosed and not on ARVs and have active pulmonary TB, they might wait a little just because of the risk of IRIS. But what's going to be correct in terms of the monitoring that we have in the US is start immediately and deal with the complications as they come. And that there is some, the only reason usually in the US to delay antiretroviral therapy would be diagnosis of cryptococcal meningitis, where you might wait about 6 weeks, or CNS TB, which you might wait about 8 weeks. But the risk of IRIS is always higher with a lower CD4 count, and we're usually able to get those. And I think in this case, waiting could be reasonable depending on how you want to parse it apart. One of our HIV team just told me on the inpatient service, basically a good motto is deal with the infection that's in front of you. So the priority here would have been TB. And sort of roadmap for HIV care at NSCH. Rapid HIV testing is free, so should be done on most patients who have any sort of suspicion. And CD4 counts are part of the clinic's treatment, but oftentimes they're out of stock or they won't do it. Some of you may have heard CD4 counts can be less useful in the inpatient setting or when patients are sick, but we can get a viral load sometimes. So some other predictors that we can use to kind of see if people are responding to their HIV treatment or adherent to it, we'll be looking at their overall lymphocyte count, which is not super sensitive or specific, of course. But once it gets really low, can be pretty specific. I've heard before and read in textbooks that oral candidiasis can be suggestive of CD4 less than 200, but take that with a grain of salt. Some of our experts at UW are less convinced that that's the case, but of course looking for other evidence of OIs, things like KS lesions, things like other skin findings. And the newly diagnosed HIV package may look a little bit different. We are able to get a serum CRAG pretty easily in the hospital, and so screen for presence of that before starting new HIV treatment. And you can screen for HBV because there are some overlap in the antiretroviral treatment, and then screening for active TB with a gene expert. And if you have a patient who has a really low CD4 count when clinical pearl, so the urine LAM test, which is a send out at our hospital, is more sensitive for patients with really low CD4 count. So it's pretty not useful in someone with a constituted immune system, but systemic TB can be diagnosed that way. And then often our patients end up on Bactrim prophylaxis for life, it's now I think sort of increasingly I've seen CD4 count limited, but used to be the practice that it'd be just sort of part of the package because PJP pneumonia is also pretty common. All right. I don't know if there was a question about that. Oh, vitamin B6. Yes, yes, of course. Goes along with our RISE therapy. Thank you. All right. So case 5, we have a 26-year-old man brought into A&E, accident and emergency, unconscious, and family says he ingested Almitraz about 3 hours ago, does not arouse external rub, and his shirt is covered in vomit. The exam was notable for vitals of 35.3, a blood pressure of 100 over 56, heart rate of 46, respiratory rate of 16, and saturating 98% on room air. Pupils were pinpoint and minimally reactive. Lungs are clear without rales of bronchi, and breathing is unlabored, has no oral secretions or diarrhea, and labs are notable for a blood glucose of 191, AST of 81, ALT of 60, and a normal BMP. And then this time the UA shows 2+ glucose, but no ketones. All right, so not an uncommon presentation, a patient with intentional ingestion. Almitraz is kind of a tick poison and really available commercially for agriculture. What would you do next after kind of doing your ABCD exam? So would you bolus atropine, double the dose every 5 minutes until bradycardia resolves, place an NG tube for gastric lavage, or administer vitamin K, or supportive care only? I feel like choice E here is phone a friend from poison control, but we don't have that. All right, so about an even, yeah, NG tube, supportive care, atropine. I think we're phoning poison control for this one. And they're going to tell us that supportive care only. So Almitraz is an alpha-2 adrenergic agonist. I wouldn't expect you guys to know that unless you worked in our setting. Really, really common for it to be mistaken for organophosphate poisoning, which is our other most common intentional ingestion. But on his exam, you see kind of some of the bradycardia, but no hypersecretory state. So the most common cause of death in organophosphate poisoning is respiratory compromise, largely because of the secretions and in alpha-2, you might just provide supportive care unless someone has really severe bradycardia, and then you're just in the bradycardic arrest algorithm and treating with atropine, which is different than organophosphate poisoning, where you might have the respiratory suppression, but you would typically have bradycardia that requires all of it with treatment with atropine dosed to the kind of wetness of the lung exam, because that's the most critical. And this is something that we actually talk a lot about with our interns and our A&E faculty. A couple of the prior chiefs and medical students have been involved in studying organophosphate poisoning presentations and outcomes at our hospital, because really it's kind of OPP is the most common one. And so people will treat that regardless of the poison. And for amitraz, it can be a little bit different and then discrepant. So we treat to clear chest with atropine. Interestingly, in this study from 2018 that we did at our hospital, 97% of ingestions were intentional. So that while they are agricultural agents and people can be exposed in their work, they were mostly intentional. And we do see other things like amitraz and then rat poison. The reason for that vitamin K choice was for super warfarin poisonings. It's difficult oftentimes to prove the original agent. So similar to that, what you would do in the US is you're treating the patient, not the agent. So really careful physical exam and responding to the type of syndrome that they're presenting with. We're able to treat some of these patients more commonly now, of course, in the ICU, be able to get them intubation. So I think overall our outcomes have improved. Most people do end up getting atropine at some point just because of the protocol being common and kind of available in terms of your differential. But this is a more widespread example of the different things that we do end up seeing. Sometimes paraffin poisoning, kerosene. Most of this is going to be supportive care, except for the really specific treatment of atropine for organophosphate poisoning. And don't forget your ABCDs. So thank you so much. Basically, clinical pearls. The fact that sometimes we lose track of the fact that each exam finding, each basic lab, each test, we're able to get actually a few of these things. So sometimes these multiple choice tests are misnomers. We're able to get that CT, the family's able to raise funds, but each test has its own kind of likelihood ratio, positive predictive value, sensitivity, and it depends on the user, right? So when we're thinking about POCUS, we're thinking about the training provided to the provider. When we're thinking about physical exam, we're thinking about whether the history has already given us some suspicion of CCF, for example, and then we're using our exam to increase that likelihood or decrease that likelihood. So I think it's important to consider those interventions as we do them. And then I wanted to make the point that, sort of using evidence-based medicine and research limited settings has a limitation of the fact that we're underrepresented in the literature. Oftentimes you're looking at studies in Malawi or Uganda, South Africa, but really each place is different. And so a lot of what our work is to kind of sponsor and promote publications and study of our own patient population. We talked about a lot of different disease processes, from the double burden of disease to cancer outcomes and primary care differences to kind of more empiric treatment versus the ability to search for every possible opportunistic infection in HIV, and then of course just the commonality of things like TB. So I'm happy to take questions in the chat. What does mental health care look like for this and other patients? So I think that's a really good question. Well, we talked about how we do have a palliative care office. It's really only one nurse. And then for OPP, things like suicide attempt, we do have a clinic where people are able to discharge kind of through the clinic. And sometimes the counselor is able to see the patient in the hospital, but more recently, we don't have a psychiatrist. And I think what I've appreciated is that attitudes around suicidality or depression are a little bit more kind of event fixed. They'll say like, this is this was done because there were disagreements with family or financial issues, or I think that we often have to discharge people to the same setting with mostly just brief intervention. And one of the pharmacists at our hospital is leading a team to study specifically our organophosphate kind of outcomes based on our protocol, but then from there, identifying like there's a particular region of agricultural work where we see a lot of our patients coming from a particular season of the year as well, and then wondering whether, like you said, we could think a little bit more about the systemic reasons why we're seeing that so much in the hospital. So that's a great question. Mental health landscape is limited. So just moving into the Naivasha rotation.
Can I pause you, Catherine, real quick? We've got one
I
other
see the next question. Yes, curious how stigma plays. Yes, yeah. So I think family, great. So HIV and TB, you know, incredibly common, but still stigmatized. I think a lot of patients will, or it's not uncommon for patients to not disclose their status originally. Unfortunately, I had a couple of cases of patients where we kind of determined too late that their HIV was really driving their presenting process because they'd been off meds and kind of not willing to accept the diagnosis for a long time, which, you know, I've also seen on the wards at Harborview. I don't think I have a big nuanced opinion about that stigma, but certainly infectious disease stigma is common. You know, you hear patients wondering why it happened to them, that they have TB, you know, that they have a clean house or they have certain practices, but it can happen just because the endemicity of the area. Things that have helped are things like having really accessible clinics at almost every outpatient center. So you have maybe a rural setting where there's just a one nurse operated clinic, and patients can come pick up their HIV meds and their diabetes meds kind of from the same window, trying to have less kind of specialized or visible care, and the understanding that people can live with HIV for a long time, certain public health campaigns, and there's a lot involved in that. But I think families are a huge part of care, particularly on the wards. While we have challenges with our visitor policy in the US, I think it's been one of the joys in our work in Naivasha that families come to see their patients at breakfast, lunch, and dinner, usually feeding them and checking in and doing some of that advocacy that we so enjoy, sort of wondering when they're going to get better and support them at home. How is the cost of the seat? Yeah, how come we have these? I really cannot. I cannot comment on how we price things in U.S. healthcare system, other than that I know it's mostly designed to get money from insurance companies, and then unfortunately patients are put in the middle of this really strange system. While it's sort of nice in some ways to kind of know upfront how much something is going to cost, it does, yeah, we kind of talk about the merits and disadvantages of this. Basically, it's nice to know that it's $70 and you've spent it and you're not going to be you know, bankrupted with an undisclosed amount at the end of the hospitalization. But at the same time, you know, a patient who needs an urgent head CT scan doesn't get one just because their family said they can't get it. So there might be delays in life-saving care. So I think that's one of the biggest differences in our healthcare expenditure is basically, you know, it's nice to be able to get all the tests that you need for the patient to take care of them, but it's also nice to be respectful of their family priorities and what might end up being a good compromise. Hopefully the hospital is going to be able to get a CT scanner itself, which will make it a little cheaper because it might be able to be covered by the national insurance, which most people do have, and that can make hospitalizations actually pretty affordable. But $70 is a really big way. And yes, so healthcare, just like in the US, is priced in a way that people can't afford it. I don't know if that answers your question, Austin. And then All right, so I'll keep answering questions in the chat while I talk a little bit more about CEPI. I don't know what you guys have heard before, but this is a photo of Naivasha from kind of above town. We are a site about an hour and a half north of Nairobi in the Rift Valley on a freshwater lake. It's historically rooted in a relationship that the University of Washington has had with a number of different sites in Kenya. Regionally, there was a program called the Medical Education Partnership Initiative, which was through the understanding that University of Washington has a number of different WWAMI sites and is strong in their training and emphasis on rural health. And the University of Nairobi was interested in having a similar training system at sites in different parts of the country. Most of the higher medical training, like residency, is done at the University of Nairobi and the Kenyatta National Hospital, where all the medical subspecialties exist. And so there was some desire to do training in the outlying communities. And the design was a PEPFAR funded and NIH program, which was designed to strengthen medical education systems and retain those clinicians to rural parts of Kenya, because clinicians at the top of their training have pretty similar training to us in the US, but there's just less availability of that training, and results in mid-level providers in rural settings having less access to that advanced training. And then MEPI became CEPI, which was just the Naivasha site, where our focus is on clinical skills and knowledge promotion, education and mentorship, and then partnerships and research. So rather than a model in which we go and sort of just provide care, although we've been there for about 10 years, and we do sometimes do direct care. I attend on the medicine wards there. Our real goal is to help advance the skills of learners where they may not be exposed to kind of our friendly environment of kind of educational exchange. We use things like bedside ultrasound, scaling up that training, and kind of provide a non-supervisorial person to do advanced CME or continuing medical education for learners. And then, so that's usually through bedside teaching. MS4 students will be back this spring in Naivasha, which we're excited about, and they can be sort of more like direct near peers to some of the interns in the hospital, and be a bilateral exchange. And then one of our important goals also is, as I alluded to, having learners from Nairobi come to Seattle for an observership, see the way that our ICU works or our specialty care works, and to participate in research to just advance the amount of publications and understanding of disease processes that they see in their setting. Naivasha is a level 5 hospital, which just means that now we have ICU beds in a number of different theaters. It's a trauma hospital, it's government hospital. Sort of the majority of folks are NHIF covered, but a good portion of them are still paying cash. I don't know if you can see in this picture, there's a cost list at the front of the hospital. So how much it costs to have a baby or be there for a night, which is some really nice transparency, but also just a reality of medical care is that it's still pretty unaffordable. The resources that we do have, so the labs, some of which I've shown, we usually have X-ray available, and then there's just local in-town medical outfits that kind of offer things like echo and CT and MRI, and they have varying costs and just start in the community. We have a dialysis unit for outpatient care, but not a nephrologist, and a pretty large new outpatient building where people are able to seek care for things like hypertension, diabetes, and TB, HIV, like an eye clinic and surgery clinics. This is an old picture of a resident and some interns reading a head CT scan, which comes out on a film like that. And you often have to read it yourself. I think this patient has like miliary TB on X-ray. This is what the ward kind of looks like. We have 247 beds, 2 surgical, 2 medical. There's also pediatric, and then lots of maternity wards. We have about 50 beds, for example, on female, and sometimes 1 to 2 beds per patient, or patients per bed. And we round usually on one gender. The residents will stay on one side or the other. And the hospital is mostly run by clinical officer interns who are folks who have done about 2.5 years of post college education in kind of an advanced practitioner role. And they are doing a rotational internship through general surgery, pediatrics, OB-GYN, and medicine. They'll be with us for about 12 weeks at a time. So similar to kind of your 3rd-year clerkship, but as if you're also the intern and primary provider. And those are our main workforce. And then they're supervised by medical officers who are folks that have done an internship and worked at the hospital for maybe a couple of years, but have not been able to go to residency, because unfortunately residency is like it costs. You don't get paid as a resident in Kenya. It's inaccessible to a lot of people. We talked a lot about common presentations. We do see some of the rarer things, and I would say the amount of testing that we do versus the amount of pathology that we see, pathology is pretty high, and usually the tests are useful. The elective is 4 weeks, and you do work clinically every day. You won't have your own patients to kind of pre-round on, but you'll rather be working with the interns and developing a working relationship. It does take time to build those relationships, so we always ask people to be patient with themselves, but you'll provide teaching presentations and common medicine topics. As you can tell from this presentation, you are prepared for that medical knowledge. It's all of the same things with physical exam and clinical reasoning, just some of the things that might be a little more challenging. And we have housing set up. It's walking distance from the hospital. These are some of our recent residents. You'll see Lauren and Nick and Jed. They're working on the wards, and one of our University of Nairobi residents, Lavender, who came in November. Also important to note wellness, just spend a good amount of time, weekends off on the rotation, being able to go appreciate some of the natural beauty. This is Shiv and Jed on Lake Naivasha, our Friendsgiving dinner and the World Cup game, just hanging out with other interns and having our kind of global health Decolonizing Global Health Journal Club, and then Jed and I were able to get up to Mount Kenya, where there was snow. I just wanted to provide my contact information. I finished quite early. This role means that I'm happy to talk to you about the rotation, about the chief year. We still are advertising for people to do the rotation when you put in for your schedules. So typically 2nd and 3rd year residents, as well as looking for a new chief for, I guess, the year after next. I'm always accessible on WhatsApp even when I return to Kenya in a week or so. And then Colette Abbott is the director of the Global Health Pathway. If you have been interested in that, or if you want to make that a part of your Naivasha experience, do research there. That's her information. She's also a prior chief and a Harborview hospitalist that you might have interacted with. And then I don't have Carrie's email in there, but I can get it for you. Sort of a tremendous mentor in the Global Health Department. She's my direct boss and also a former Pathway director who spent a lot of time in Kenya, has a number of different research projects and connections there if you're interested in kind of more of the research side of things or getting a perspective on other programs and connections that are available through UW. I have one question. Yes. Thank you, Shiv. No global health experience is necessary. Of course, we'll usually kind of ask why you're interested in doing the rotation, but that's largely just so we can kind of cater to your needs. Everything from people who may be experiencing that setting for the first time to those who might think about practicing long-term in a global health environment. Any other questions before I give you, I guess Kayla gives you a break. One more. Is it cold? Yes, John, I think it's finally colder in Seattle. Although we do, yeah, you can get up very high in Kenya.
All right. Well, I think certainly if anybody has last few questions trickling in, feel free to shout them out or put them in the chat. But Catherine, thank you so much for speaking to us. I think I probably speak for everybody when I say that this was fascinating and really appreciate your time. I think our next talk with the wonderful Dr. Sylvia Stellmacher is supposed to be at 10:45. So we've got about half an hour here. Looking to see if Sylvia's with us yet, I'm not sure. So it may make the most sense for us to plan to just take a nice luxurious break.
I just saw her pop onto the screen.
Okay, I had seen her a minute ago, so I wasn't sure. Oh, hi, Sylvia. Not hearing you, I'm seeing your mouth move. If we can get my audio working, we can start in 5 to 10 minutes. Yeah, I think, why don't we plan to take a 10-minute break and then we'll get you guys going early today. So let's everybody come back. I guess let's call it 10:15 now. So come back at 10:25 and we'll get started up again. 10:25.